Hi, good evening, and welcome to our webinar on pregnancy and cardiac disease. My name is Katie Young. I'm a cardiologist here at Mayo Clinic, and I'm joined tonight by two of my colleagues. We have Dr. Carl Rose. He's an associate professor of obstetrics and gynecology and specialist of maternal fetal medicine. And we also have Dr. Charlie Jane. He is also a cardiologist who specializes in adult congenital heart disease. As you all know, the breadth of cardio obstetrics and cardiac disease in pregnancy can be very broad, can cover congenital disease, acquired heart disease, and we will not have time this evening to cover all of that, but our goal is to go through some cases and get high yield teaching points from each of those cases that you can take and use in integrate into your clinical practice. As a reminder, there will be a Q&A at the end of our presentation. Please, throughout the presentation, you can put your questions in the Q&A and we will go through as many as we can after our presentation. So these are our learning objectives. So first, we'll review the importance of specialized care in the pregnancy heart team. Next, we'll briefly highlight the hemodynamic changes that occur during pregnancy. And then the largest portion of the presentation will be going through three cases, which highlight various aspects of management of cardiovascular disease during pregnancy. The topic of cardiobstetrics is so important because maternal mortality remains very high in the US and is more than twofold higher than other developed countries. And unfortunately, despite our efforts, recent data demonstrates that maternal mortality rates are continuing to increase in the US. In 2021, maternal mortality rate was 32.9 per 100,000 live births. And when we look at causes of pregnancy-related deaths in the United States, and we look at cardiac conditions, cardiomyopathy, and hypertensive disorders of pregnancy and combine them, that makes up the largest portion of contributors to pregnancy-related deaths in the US. Age is an important risk factor. More women are having children in later childbearing years, at which time there's higher incidence of other cardiovascular disease risk factors, which likely contributes to the higher pregnancy-related deaths seen in women 40 and over. And there are significant racial and ethnic disparities, with maternal mortality rates peaking among non-Hispanic Black women.
Well, thank you, Dr. Young. I would like to introduce the idea of the pregnancy heart team, or the field of cardiobstetrics. And generally, in terms of management strategies, this will be comprised of my cardiology colleagues, some from obstetrics, my anesthesiology colleagues, my social work, my labor and delivery colleagues, geneticists, pharmacists, sort of on an as-needed basis for each individual patient to construct a plan for clinical management. This highlights some of the guidelines that have been introduced by our major sanctioning organizations for reference. And just a note on some of the physiologic changes during pregnancy. And typically, we will see cardiac output increase during pregnancy, usually even in the first trimester. Typically, this is going to peak somewhere in the neighborhood of 28, 32 weeks gestation. Correspondingly, we see a drop in the systemic vascular resistance, usually starting in the first trimester, reaches its nadir somewhere in mid-pregnancy and slowly comes back up to normal by the early postpartum interval. And correspondingly, we see blood pressures usually fall, again, reaching their lowest point in the mid-second trimester, sometimes peaking a little bit during the labor process, and then returning back to normal. All of these physiologic changes typically resolve by about 6 to 8 weeks postpartum. Now, corresponding changes that one might find on an echo obtained on a pregnant patient would include usually an increase in transvalvular gradients across all the valves. We will see a small degree of regurgitation across all the valves, but importantly, the ejection fraction, both left ventricular and right ventricular ejection fractions, essentially remain unchanged. So to shift gears for a moment and go into some clinical cases here. So our first case is a 32-year-old who presents for preconceptual counseling. She has an innocent history of non-compaction cardiomyopathy, and like many of these patients, she has experienced an arrhythmia, ventricular tachycardia in her case, for which she's undergone radiofrequency ablation and a prophylactic RCD placement. Unfortunately, she also experienced a right embolic MCA stroke and is currently managed with therapeutic anticoagulation using warfarin. So here's an image of sort of her cardiac function. And of note here, I draw your attention to the fact that her LVEF is 34% and her RVF is 30%. So current medication regimen consists of warfarin, a dose of 4 milligrams a day, carvedilol, spironolactone. And you'll note that hemodynamically, she is stable. She's essentially asymptomatic and is able to participate in activity on a regular basis. So how should we counsel this patient? What would you recommend to her? Normal pregnancy care, more complex pregnancy care and delivery at a tertiary center, or to avoid pregnancy altogether because of the associated risks? Well, in this situation, we would usually counsel based on the modified WHO criteria. And looking at her values for ejection fraction, once again, 34% for an LVEF, she would fall into modified WHO class 3, which would incur, as you see there, a relatively substantial risk of a cardiac event either either during or following the pregnancy. In these situations, the patients would typically be evaluated on a frequent basis, and delivery should occur in a center that is able to manage any potential intrapartum or postpartum complications. So just a note on maternal levels of care as they are listed here. In this situation, typically we would recommend a patient deliver in a level 3 or level 4 center. Once again, in the event that something occurred during the labor or the delivery process, that she could be managed in that facility and not necessarily transferred elsewhere. So a few words on non-compaction. This is our experience here at Mayo. Very few patients were actually diagnosed prior to pregnancy. About a third of patients were diagnosed actually during pregnancy or during the labor, delivery, postpartum process, and actually presented with heart failure. And the good news is the majority of patients actually tolerated the pregnancy well, and outcomes were favorable, if you will. So a few other thoughts in this particular situation that we must address is anticoagulation management, the option of prenatal genetic testing for her infant, and also screening for congenital heart disease in her infant. Now, when we look at our options for anticoagulation, she is currently managed with warfarin. Now, warfarin during pregnancy does cross the placenta, and actually we see an enhanced anticoagulation of a baby as a consequence. There's a risk of warfarin embryopathy anytime in the first trimester, most pronounced, typically in the 6 to 9 week interval. It is dose related. When patients are on less than 5 milligrams per day, the risk seems to be lower. Now, unfractionated heparin and low molecular weight heparins generally tend to be the favorite anticoagulants during pregnancy, with a nod given to low molecular weight heparin because of its more predictable response. Unfractionated heparin is of course also used primarily in situations where anticoagulation needs to be started or stopped on a relatively short-term basis. Any of these can be used during lactation, and also of note on here, at present, we do not recommend DOACs for use either during pregnancy or during the postpartum interval. So in this situation, we advised her that she was able to proceed with pregnancy. Always a concern with anticoagulation, but also unpredictable, is she may be a candidate for neuroaxial anesthetic, either an epidural or spinal in labor, depending upon her anticoagulation status at the time. Carvedilol was continued, spironolactone was discontinued due to concerns regarding anti-androgenic effects. And in this situation, after discussion of the options, she was transitioned in advance of conception to low molecular weight heparin.
Thank you so much, Dr. Rose. And I feel like I really need to say thank you so much for all your help with all of our patients. You know, you mentioned the pregnancy heart team a few slides back, and without a doubt, the multidisciplinary nature of care for these patients is really, really important. I think these can be really challenging patients, and working side by side with my maternal fetal medicine colleagues, I think makes it for a huge advantage, and we're very grateful to have you and all of your colleagues. So thank you. We'll go on to another case here now, moving to valvular heart disease in the setting of pregnancy. And so case 2 is a 28-year-old woman, G1P1. She just had a baby a few months ago, and you're seeing her for a routine postpartum visit 3 months later. She has a history of unicuspid aortic valve stenosis. She had a 23 millimeter Edwards pericardial magna aortic valve replacement 5 years prior to this pregnancy. Now, right after that surgery 5 years ago, her fingerprint mean gradient across the valve was 12. Prior to this pregnancy, just immediately before, her gradient had increased to 23, so she did have some early prosthetic valve degeneration. At the peak point of pregnancy, and as Dr. Rose described for us a few slides ago in terms of the hemodynamic changes, usually we start to see the peak of the hemodynamic load around 24 to 28, and certainly by 32 weeks is a time that we'll often repeat that assessment with a transthoracic echo. Her gradient had increased to 31. And so remember, with the increased amount of flow and cardiac output, which is appropriate for pregnancy, we will, of course, see an increased gradient. There's more flow going through the same size valve. Now, whether or not from 23 to 31 is more than we expect can be really, really hard to assess, but it doesn't seem extraordinary here. So now we're seeing her 3 months postpartum, and by that point, we would expect that those hemodynamic effects of pregnancy have all resolved. She should be back to her baseline hemodynamic status. The flow's decreased back to her normal cardiac output, and we expect that the gradient should go back down to 23 or something comparable to her pre-pregnancy. But in this case, the patient's mean gradient across the valve was actually even higher than at the peak of pregnancy. Therefore, this suggests that there is certainly some wear and tear on this valve throughout the course of pregnancy, which we can see. We don't necessarily expect it, but we certainly do see this. And there's been a lot of data looking at this. So for this patient, when we think about what's her modified WHO classification at this point, if she said she wanted to get pregnant again, she's falling into that modified WHO class 2 to 3, or almost into the 3 category here. And so we told her, well, we'll follow up in 1 year. Certainly, if you get pregnant in the meanwhile, you need to let us know immediately. So, of course, she comes back 11 months later, just shy of that 1 year time point. And at that time, she's 9 weeks pregnant and she's not feeling well. She's had some recent dyspnea on exertion. So even though the hemodynamic changes of pregnancy are quite minor in the first trimester, they certainly are present. And for this patient, it seemed to make a difference. On the right, you see her transthoracic echo parasternal long axis view zoomed in on her aortic prosthesis, and you can see that it's heavily calcified and relatively immobile leaflets, quite concerning here. So now we put a continuous wave Doppler through that aortic prosthesis, and we get a severely elevated velocity here. And when we look at the mean gradient across there, it was 110. So she has critical aortic prosthetic stenosis, and it's significantly increased from 1 year prior, highly concerning. So of course she was admitted to the hospital straight from the echo lab. She had an urgent transesophageal echocardiogram performed. There is of course suspicion for thrombus. We saw an acute change in the gradient. She's pregnant, a hypercoagulable state potentially. The TE did not show any evidence of thrombus. It did show that there is significant prosthetic aortic regurgitation. And then as you saw in the 2D on the last slide, there's been significant calcific degeneration of this valve quite precipitously over the past year. So what would you recommend at this point? A, urgent cardiac surgery. B, valve-in-valve transcatheter aortic valve intervention. Or C, pregnancy termination. Notably, there's no option D, consult the pregnancy heart team. So, I think all these considerations may potentially be appropriate for the patient, depending on the setting that you're in and the expertise available there. So let's walk through these a little bit more. When we think about catheter-based interventions for the management of a valvular heart disease during pregnancy, there's a really nice review article published about a year ago in JACC Advances. Some of the important considerations they mention relate to radiation. So for any transcatheter valve procedure, most of them, we like to get a pre-procedural CTA. And so there, of course, is a significant radiation. And if this is in the first trimester, when embryogenesis is still occurring, that's a very significant risk. And then, of course, at the time of the actual catheterization, there's, of course, the radiation from the fluoroscopy. The authors of this article actually recommend that, as it's usually femoral access, they recommend using long sheaths. to minimize the radiation to the uterus during catheter exchanges. So now in terms of data for aortic valve interventions performed from a transcatheter fashion, while there probably have been many more performed from actual published data at the time of this review article, there's only 14 balloon valvuloplasty cases published, all native valves, none prosthetic. And then in terms of transcatheter aortic valve replacement, there is 7, and only 1 was a native valve that happened to be a patient with bicuspid aortic valve and certainly had complications. Fortunately, no fetal complications published. So back to our patient, like we mentioned, she's 9 weeks pregnant, and she has a severe prosthetic aortic valve stenosis with some regurgitation. And she did undergo a pre-procedural CTA. We discussed her at our multidisciplinary conference, including with surgeons as well as our MFM colleagues. And we recommended a TAVR, but then she had the CTA and it showed the coronaries were too low to allow for a safe valve-in-valve procedure. So therefore, she was referred for urgent cardiac surgery during the first trimester of pregnancy. So now what do we know about the safety of cardiopulmonary bypass during pregnancy? Well, we looked at that here a little bit over 10 years ago. And in a little bit over a 30-year time span, we had 21 pregnant patients who underwent cardiac surgery. Most of these were for aortic and or mitral valve replacements. And most of these were emergency surgery. So as we know, even outside of the setting of pregnancy, emergency surgery carries a much higher risk for the patient. So there's certainly going to be elevated maternal mortality. But fortunately, in this series, maternal mortality was quite low, with only 1 early death in the series. Now, fetal complications are certainly significant, with at least half of the babies being born preterm and 3 pregnancy losses. Outside of Mayo, there was a meta-analysis published about a year ago in EHJ, and it's a really nice study. They do show that, just like I mentioned, with any emergency cardiac surgery, the risks are elevated for the mom, ranging from 4 to 12%, depending on the trimester there. But I think what's really notable about this study is what significant fetal mortality risk there is. Certainly it's highest in the first trimester, as we might expect, but it is not insignificant, 29 to 33%, even in the second and third trimester. So really, we have to be quite thoughtful about this and do not take this decision lightly. So for our patient, as the coronaries were too low for transcatheter intervention, she did undergo a bioprosthetic surgical aortic valve replacement with a root enlargement. Here on the right, you can see her explanted valve, which is heavily calcified, as we saw in the echo, significant pannus formation, no obvious thrombus. Now, usually for a new tissue aortic valve replacement, we would place them on warfarin for at least 3 months. But because she was still in the first trimester, and as Dr. Rose mentioned, the warfarin embryopathy, we avoided warfarin initially for her, just used aspirin. And then a couple weeks later, as she entered the second trimester, warfarin was started for 3 months. She was later induced at 38 weeks. Unfortunately, had a healthy baby. She had no further cardiac complications. And in terms of her echo, at the time of dismissal from aortic valve surgery, her mean gradient was 26. And at the peak of pregnancy, a few months later, it went up to 28. So it didn't increase significantly. And the postpartum looked very good as well. So thank you.
Very good. Thank you so much. So I'm going to be moving us on to our final case, case 3. And again, just a reminder, any questions, feel free to post them in the Q&A, and we will start addressing them after we finish our cases. So case 3 is a 34-year-old female. So she is presenting 5 days after a repeat C-section with symptoms of dyspnea and headache. And her notable history includes gestational hypertension with a prior pregnancy, as well as gestational diabetes with her most recent pregnancy, and other comorbidities, including RA, obesity, and sleep apnea. At her presentation, she was markedly hypertensive. Chest X-ray demonstrated mild pulmonary edema. Her biomarkers, her troponins were elevated but flat, and her NT-proBNP was elevated. Her renal function was normal, though a UA did demonstrate proteinuria. And so when you're seeing this patient and thinking about it, kind of thinking of our buckets of hypertensive disorders of pregnancy, thinking about which one this patient would fit under. And here on the next slide are the definitions of those. And what's important to highlight is that our patient was presenting with features consistent with preeclampsia, and this can occur, severe hypertension and preeclampsia can occur in the postpartum period. And, her presentation, as I mentioned, was most consistent with preeclampsia with severe features. And a few notes on that and the importance of preeclampsia in women, and noting that in their history, as many papers have shown, there's increased risk of these women later in life, increased cardiovascular mortality, increased risk of coronary disease, increased risk of heart failure. And so for any woman you're seeing in your cardiology practice, obtaining that obstetric history and history of hypertensive disorders of pregnancy, gestational diabetes, preterm deliveries, these are important things that should be incorporated into your H&P for all your patients. And Dr. Rose, could you comment on aspirin prophylaxis?
Yeah, so just a few words on aspirin. Since late 2015, the USPSTF recommendations have suggested that low-dose aspirin, 81 milligrams per day is the current in the United States dose, seems to reduce the risk of preeclampsia in patients with previous early onset preeclampsia by about roughly 20%. And we have extrapolated that to multiple other indications at this time, including antecedent history of preeclampsia, or in particular, a patient with chronic hypertension who is going to be at substantial risk for development of preeclampsia. So to draw your attention, this trial was published last year, CHAPS trial, essentially looking at patients with chronic hypertension prior to pregnancy, in whom we'd always treated previously down to a level of less than 160 over 110, suggesting that the incidence of superimposed preeclampsia requiring late preterm delivery prior to 35, or requiring delivery prior to 35 weeks, was lower in patients if we targeted lower numbers and keeping their blood pressures in the range of less than 140 over 90. So essentially a lower threshold to start medications than historically we had used.
Perfect, thank you. And when we think about what medications to use for hypertension and pregnancy, for your reference, here is a table outlining which medications are safe both in pregnancy and in lactation. And notably, labetalol and nifedipine in pregnancy are certainly kind of our first line treatments for women with hypertension in pregnancy. And remember that ACE inhibitors and ARBs should be avoided in pregnancy. So back to our case. So given her presentation, looking for cardiogenic causes as additional cardiogenic contributors to her symptoms, a transthoracic echocardiogram was obtained. And as you can see in these images, her LV was markedly and severely dilated, and her LVEF was reduced at 37%. And we had no prior history or transthoracic echo imaging for this patient. So presumably a new reduction in her LVEF. And I remember she's in that 5-day postpartum period. So certainly her timing of presentation is concerning and would be consistent with peripartum cardiomyopathy. And remember, the definition of such is a new cardiomyopathy, which is defined as an LVEF less than 45% without another etiology. So certainly is a diagnosis of exclusion. You still want to think about other causes of cardiomyopathy in women. But again, given the time course, this patient's case is seemingly consistent with peripartum cardiomyopathy, and there is a coexistence and overlap with the hypertensive disorders of pregnancy in about 40%. We know that women that present with lower EFs, more dilated left ventricles, and RV involvement have worse outcomes and worse recovery. And prior studies have also shown us that many women tend to recover within 6 months, and that major cardiovascular events, so needing a transplant, LVAD, or mortality and death, almost exclusively occurred in women with EFs less than 30%. Data from here at Mayo from a community cohort showed incidence of peripartum cardiomyopathy of about 20 cases per 100,000 live births. And of the 48 confirmed cases, 43 of those did recover. There was one death in the group. And there were 6 women 6 of 23 women that had subsequent pregnancies did relapse, but all of them recovered LV function. Another publication, similar community patient cohort, again demonstrating that the rate of peripartum cardiomyopathy relapse. So again, here we're looking at subsequent pregnancies in women with a history of peripartum cardiomyopathy. the rate of relapse was about 21%, with the EF at that time going to be about 43%. But again, all of these women with relapse did recover their LV function. So what about management of cardiomyopathy and heart failure in pregnancy? So again, medications are important, but there are certain medicines that we can and cannot use during pregnancy, preconception, as well as in the postpartum period. For our patient, she was breastfeeding, she was postpartum, so we did initiate her on medical therapy with beta blocker, ACE inhibitor. She was also started on spironolactone and did need some diuretics as well. As far as counseling for future pregnancies, this is also a really important thing not to forget. So when you see a woman that has a history of peripartum cardiomyopathy, or you're seeing them with this new diagnosis, we should always be thinking about and counseling regarding future pregnancies. What are their pregnancy wishes? Are they planning another pregnancy? So we can even start that process very early on. And it's important to note that women that do not recover their LV function, which is defined as an LVEF of 50%. So women that do not recover and their EF remains less than 50% are modified WHO class 4 and are advised against pregnancy because they are at a higher risk of relapse with more morbidity and mortality. As far as future directions in peripartum cardiomyopathy, it can be very challenging. Women can present with symptoms that overlap with heart failure that are normal in pregnancy as well. So the need for an easily applied screening tool to help catch these women earlier is certainly needed. And here there has been promising work looking at using AI ECG algorithms and detecting low EF in women that are pregnant and postpartum. And certainly be watching soon for additional data coming from prospective studies looking at the use of these algorithms in pregnant and postpartum women. So for resolution, kind of going back to our case, so she remained in the hospital for about a week. She was diuresed, initiated medical therapy. She did have a CT coronary angiogram, which showed normal coronary arteries. In the outpatient setting, we did do a cardiac MRI, which was fairly bland, showed no delayed enhancement. Her genetic testing was also negative. And in follow-up for about 4 months later after her initial presentation, we were beginning to see some improvement. Her LV was smaller and her EF had improved to about 47%. So in summary, that kind of wraps up our cases here. As I mentioned, starting this, care of the pregnant woman with cardiovascular disease covers a wide clinical spectrum. So it's important to have, colleagues in maternal fetal medicine and even within all aspects of cardiology to help guide these decision-making for these patients. And the multidisciplinary care and the pregnancy heart team is really essential in helping care for these women. And with that, we thank you and we'll open it up to questions. And I'm going to just switch over here to this so I can read through some questions here.
We have plenty of time here, so please, we encourage you to insert your questions into the Q&A and hopefully we can address all of them.
So first question here, when is pregnancy a complete contraindication? So
We should
go back. We're going to go back. Yep, let's go back.
Sorry, I thought there'd be a way to jump there.
Modified WHO class 4. And generally speaking, this is most likely in patients who have pulmonary hypertension, patients who have severe mitral stenosis, severe aortic stenosis, or have an ejection fraction less than 30%.
And that prior peripartum cardiomyopathy.
Unresolved prior peripartum cardiomyopathy.
Yep,
correct.
that would be another kind of category for that as well. And then another question, is spironolactone safe in breastfeeding? So we do tend to use it clinically here for women that are breastfeeding. Dr. Rose, I don't know if you have any others.
No, the use of so a little bit of editorial there. We generally avoid spironolactone during pregnancy because there are concerns, theoretical, for anti-androgenic effects. However, there's really no human data that actually supports that. And it always just seemed sort of paradoxical to me that there's some medications that we use during pregnancy, but we don't use during lactation, which doesn't always kind of seem to be synonymous, if you will. In terms of safety, I think we would look at each individual patient and ask risk-benefit approach in those cases.
And next question is for the last patient we presented, so the peripartum cardiomyopathy patient, her EF did not recover. She should be counseled on no more pregnancies. That is correct. So she, the caveat to that being, I mean, she was, this was kind of her first initial check. So she was kind of this was kind of 4 months after her. So, she's still actually coming back to clinic and we're still following her. But if her EF remains reduced, LV quite dilated as it is, that is correct. She should be counseled on no additional pregnancies. And right now we've counseled her that we would not want her to be pregnant, and we make sure she has a contraception plan in place.
And just as an editorial there, since we do rarely see mothers whom we counsel against pregnancy, I try to emphasize to them that future pregnancies for themselves are contraindicated. However, biologically, they could potentially have a child through use of a surrogate. So it doesn't preclude future children. It just means from a maternal risk perspective, it would be unwise.
Very good. And Dr. Rose, this might come to you again, but how does your team decide vaginal versus C-section?
Great question.
Yes.
So I will preface this by saying that the ROPAC group has a wonderful publication where they looked at all the different permutations of delivery, either planned vaginal delivery with emergent cesarean section, planned cesarean section with vaginal delivery, sort of all the different manifestations that one could anticipate, and they could find no difference in outcomes. We will typically make that decision primarily contingent upon the resources that they required for each individual patient. And as a practical matter, there's not a single answer to that question. If we have a patient, for instance, a scenario, if we have a pulmonary hypertensive mom who we need to have nitric oxide available for, and we really need sort of from a resource allocation and personnel availability to have that delivery occur on a planned basis. In those situations, we would suggest cesarean. In moms who have a mechanical heart valve, in whom sort of the timing or the window of time that they're off anticoagulation may substantially increase their risk for clotting the valve. In those cases, similarly, we would advise cesarean section, mostly from a logistics perspective in those cases. But I would say each case is individual. Yeah, good question. No really simple answer to that.
Yeah.
And then if I may, just in terms of that, in terms of other potential indications, maybe Katie, would you want to discuss a little bit about uretopathy in pregnancy?
Yeah, and we can certainly, because that would be one other potential reason why we may prefer a C-section, would be women who have had progression of their aortic dilatation during pregnancy, or at a significant rate, or who's are coming in pregnant and their aortas are quite dilated. And again, that is a little dependent on the etiology of the aortopathy. So if we kind of can go down.
Sorry, it's 2 slides here. I wasn't sure if there's a way to skip.
We'll go down and show. But for instance, if it's a bicuspid aortic valve related aortopathy, we generally look at the cutoff of around 50 millimeters above that, which, and then certainly for the cutoffs are lower for women with Marfan, Loeys Dietz, Turner, et cetera, kind of as we have outlined here. And I guess from a maternal fetal medicine perspective, any particular cutoff and rate of change too.
Right, that probably would influence this as well. Again, exactly as you've highlighted, lower threshold in patients with underlying prenatal genetic conditions, particularly sometimes if there is a family history of dissection as well.
Yes.
That can influence decision.
Yep. So here's another question. Patient with history of peripartum cardiomyopathy with LVEF recovered to more than 50%. Is pregnancy contraindicated, or would you consider case by case?
I would say in that situation, I'm just going to flip a couple slides back by one of our wonderful former fellows, looked at that data from our institution. And essentially, of the patients who had recovered, as you see there, 21% had a relapse. And interestingly enough, that relapse did not always occur in the subsequent pregnancy after the index pregnancy. In other words, some patients had an episode of peripartum cardiomyopathy, had an uncomplicated subsequent pregnancy, and then had a relapse in the third pregnancy, if you will. But all of those patients improved and they got better afterwards. So that has changed our counseling in this situation. We generally quote, our numbers there are within the range of what's usually published in the literature, 25% plus or minus 5. And so we don't counsel against future pregnancy if it truly is recovered LVEF.
Yep. And a couple of things to consider there. So totally agree. I mean, it's a shared decision making, but again, I would not be going in, like you said, thinking we would have to counsel against pregnancy. We'd also need to look at their medications, because certainly that's another thing. What have they been on for medical therapy? Because many of those may need to be discontinued prior to conception. So that takes a lot of, some planning as well. And sometimes even after stopping some of that therapy and allowing some time to pass and rechecking the LV function before they become pregnant, it's helpful also. So we have another patient here, or another question. In young patients who have severe AS, maybe congenital, but in their early 20s, they need a valve replacement. How do you counsel them regarding bioprosthetic versus mechanical? And how do you decide?
Who wants to field that?
Yeah, that's very good question.
Yeah.
Very good question.
I think it's really controversial. If you want to go for it, please.
You should go. Yeah.
I don't know if I should, but I guess I will. So really controversial. And I think it really comes down to patient-centered decision-making, shared decision-making with the patient. And it also depends on your surgical expertise nearby. So I think if we're talking about patients with significant aortic stenosis who require valve replacement before considering a pregnancy, as we learned, or as we discussed, anticoagulation in the setting of pregnancy, if it can be avoided, I think it really should, both for the mom and baby's sake. And so in patients who are resolute that they certainly want to have their own child and not through surrogate or adoption, they're resolute that they want to have their own baby. I mean, you have a thoughtful discussion with them, discussing the risks. And then in terms of that situation, generally, and again, a case-by-case basis, but we would recommend against a mechanical valve. And so then the options being a tissue prosthesis or alternative procedures, such as the Ross procedure. Again, then that gets back to your surgical expertise nearby and patient decision-making and what they think about pluses and minuses of each approach. No approach is perfect for mom or baby, but oftentimes here, at least in our experience, I think we would recommend against a mechanical valve. But I think, this kind of highlights this whole point of in patients with known cardiac disease, women in their childbearing years, even in a visit where it's just routine follow-up and you're not talking about pregnancy, it's not on their mind. I think it's really, really essential that we mention it. They're of childbearing age, and if pregnancy is not on their mind, then are they on contraception if they have a high-risk cardiac condition? I think it's important and appropriate to discuss it. And if the patient doesn't want to discuss it, that's a different story. But I think as our job, it's really important, because when this comes up and they're modified WHO class 3 or sometimes 4 and they are pregnant and it's never been discussed, it's a really, really challenging to backtrack. So.
Yeah, preconception counseling, definitely important for women with heart disease. Congenital, acquired, absolutely. Next question is, any guidance on patients that may require telemetry as an inpatient during admission for delivery?
We do that. I'll field that one. We do that in our labor and delivery. And it's typically patients who have frequent arrhythmias late in the third trimester. It generally tends not to be, I guess that sort of harks back to delivery in those patients at level 3, level 4 maternal care center. Our if you will, arrangement here is a patient will be on telemetry. Our ICU is 7 floors up. So the ECG is monitored in the ICU during labor. And if someone has an arrhythmia, usually the ICU will send someone down, manage it there. Very rarely, actually, will be transferred up to labor and deliver or up to the ICU, but it actually works incredibly well. It's sort of a, if you will, synchronous care.
And we do have a small subset of patients then that we kind of transition briefly to the ICU postpartum in that kind of 24, 36 hours after delivery and continue that monitoring.
Right. We expect a lot of hemodynamic changes in those situations, all the intravascular, extravascular volume shifting. As the uterus contracts, it sort of gives an immediate auto transfusion of probably about a unit and a half. And just to sort of be in as an area, might be the best way to put it, that can manage acutely any type of cardiac decompensation.
And next question is, for those moms with reduced EF, how does the team decide on invasive monitoring?
It's pretty rare here that someone requires invasive monitoring. My anesthesiology colleagues generally will go based on non-invasive monitoring. The only time I've seen that be an issue is in pulmonary hypertension. In those situations, a swan floated. But otherwise, I guess I'd say our institutional preference is generally to avoid, if possible. With the exception, I should say, invasive monitoring, heart lines for patients who have stenotic valves, particularly AS, in whom cardiac output monitoring and accurate blood pressure assessment is important. I think of invasive monitoring as central lines.
And perhaps if it's okay, slight aside, but in terms of, as you mentioned, catheterizations and pregnancy, I think for women, as we described, there's increased flow throughout pregnancy, which is appropriate. So even values such as the right ventricular systolic pressure and echocardiography, it's appropriate, should increase some, but sometimes there's women where it increases more than expected. And there's this question of, do they have pulmonary hypertension that wasn't previously diagnosed? And I think, in those situations, and there's, again, patient-centered discussion about whether or not you should proceed with diagnostic catheterization during pregnancy. I think, in many ways that can be achieved at very low risk to the mom and baby, and maybe most appropriate if we're talking about, well, then what are the potential risks of proceeding with a pregnancy in a patient with pulmonary hypertension, trying to associate and actually calculate what's the pulmonary vascular resistance, not just appropriate increases in flow. And so I think, in those situations, it can be considered and can be done safely, but of course we reserve it for when we really need it.
Okay, very good. And what is your approach, our approach to symptomatic resting sinus tachycardia in patient with a mild anemia of pregnancy, but with a structurally normal heart? So symptomatic tachycardia, mild anemia, structurally normal heart.
Metoprolol.
Yeah, no, and we do use metoprolol, so beta blockers in
beta
pregnancy. Yep. So we do use metoprolol. Certainly, I would make sure obviously excluding all other, sinus tachycardia, excluding all other contributors that could be driving that. But if the patient she's really symptomatic, metoprolol certainly could be considered.
Yeah, I mean, maybe considering a 24-hour halter just to make sure we're not missing any type of another arrhythmia. But yes, I mean, beta blockers in pregnancy have been associated, and we use that term loosely, with fetal growth restriction. But in these situations, if there's a substantial maternal benefit, then we would typically do so, and perhaps look at growth ultrasounds in the third trimester.
Okay, next question. Looks like I have a patient-related scenario. So patient with congenital critical AS status, so neonatal treatment, and subsequent four additional surgeries. So they had a Ross, they had an aortic root pseudoaneurysm repair, bioprosthetic AVR, septal myectomy, RV to PA homograft. Current functional 21 millimeter Onyx AVR, normal LV function. How does 5 prior cardiothoracic surgeries affect your recommendations for pregnancy?
Really good question, really complicated patient.
Yeah.
And unfortunately, we see this commonly. And I think, one of the current limitations of the data that we have or the guidelines that we have, the modified WHO and Cardiovascular risk scores are fantastic. But one thing that is missing, in my opinion, is incorporation of functional status. And so, you can have a patient with, such as this patient, or a patient with, asymptomatic significant valve disease, but what their functional status is impacts your management significantly. If we take this outside of the context of pregnancy and you just think, well, how is this patient doing and how do you think they would do with, non-cardiac surgery or something else? Again, it gets back to what's their functional status. If they're feeling short of breath going up the stairs, you're going to be more concerned about them than if they exercise every day. And so, I think that's a really crucial piece to decision-making there. With the assumption that that patient's functional status is good, they're asymptomatic, valves working well, as you mentioned, the left ventricular function's okay. We're also assuming the RV to PA conduit is without significant disease, the right ventricle is doing well. Certainly they would be at increased risk, but if their functional status is okay, then you would think that, well, their overall risk for maternal complications is not as high. Now the major thing just comes in about the anticoagulation. And then that approaches similar to any other patient with anticoagulation, and it's not insignificant. I think there's this question out there of, with the onyx valves, maybe there's this lower thrombosis risk. Could we manage them a little bit more loosely or conservatively? But I don't think we have any data to support that yet. So the risk that we would think about with anticoagulation in any woman in pregnancy would be comparable for this patient. There's a nice JACC review article from a couple of years ago, which has a nice pictorial to help guide decision-making in those situations. And I think you just have to have a really thoughtful conversation with the patient, make sure they recognize the significant risk to them as well as to the baby. And then, as we've mentioned, consider alternative options, surrogacy and or adoption.
Good. Next question is, so in a patient with peripartum cardiomyopathy, their EF normalized with therapy. When do you consider stopping the ACE inhibitor and or beta blocker? So that's a really good question. And I'll kind of take first go at that one. The generally at least therapy for at least a year is kind of generally postpartum. But I think I discuss a lot with my patients too, if they're not planning, like such as a patient not planning additional pregnancies, if they're tolerating the medications well, they're not particularly symptomatic or they're not bothersome to them. I do consider at least keeping some sort of medical therapy ongoing. And there's not a lot of per se data for that, but there is one study, the TRIHF study, which did show that when medical therapy was taken away or stopped, and there was a very few number of peripartum cardiomyopathy patients in that, these dilated cardiomyopathies did tend to things got worse. Their LV redilated, their EF could go down again. And clinically, I have seen that as well, where a woman stopped therapy, keep following her, and then the next echo, the LV was a little more dilated. The EF is now down like 49, 50. So if they're tolerating it, I kind of treat them like a dilated cardiomyopathy and would encourage them to stay on the medical therapy if it's not particularly bothersome, or at least one of them, maybe the metoprolol, if they want to stop the ACE inhibitor, it's a discussion. It's a discussion and each patient's a little different. But I certainly wouldn't want them to stop anything for at least a year postpartum. Okay, so in patients with Marfan's with normal aortic size versus those with a dilated aorta, how often during pregnancy and when postpartum do you assess for aortic size?
I can probably feel that one, and I will tell you that our institutional preference here has been to echo our patients with Marfan's on a monthly basis, all the way through the pregnancy. And we don't see very frequently a mom with Marfan's and a dilated aortic root. I think in those situations, we might have to have a frank discussion about the advisability of pregnancy. But in those cases, I would anticipate we would echo moms once again, probably on a monthly basis, and then postpartum actually prior to discharge.
Mm-hmm. And
And
then,
would you guys do anything different?
no, and then I was just gonna say that kind of
Yeah.
6
weeks, yeah.
weeks following.
Yeah.
So kind of prior to dismissal and then having that follow-up before they leave the hospital as well, kind of right, but after that.
I guess I may just kind of bring up the question of, in terms of method of evaluating, if you want to talk about multimodality imaging in pregnancy. In terms of MRIs, how often will you tend to use those?
Yeah, so I guess I would say, so MRIs, and they can do MRAs without contrast. And I would think clinically myself about doing that. So echo's great. Obviously, there's no radiation, there's no, it's easy, it's ultrasound. But if there was concern that there's been a change, so if you're seeing a change or, clinically something is different, then that's when I would probably trigger to do the MRs. Or if things are stable, and again, even postpartum, again, you watch them in that close time frame, again, kind of re-imaging after the pregnancy. But certainly if there's a clinical change or you're concerned or something's rapidly changing on echo or you can't see it very well, certainly then you'd want to consider looking at cross-sectional imaging. Absolutely. The next one says pre-pregnancy counseling. So certainly important. I don't know if it's maybe how we do that here or because I think for a woman with cardiac disease, certainly having them meet with maternal fetal medicine as well as cardiology and having a similar message to the patient as well, I think is really important. And then oftentimes that pre-pregnancy assessment may include exercise testing, basic lab evaluation, EKG, echo, most typically.
One of the things I would say when we do in the rare instances where we recommend against pregnancy, I always offer, once again, the option of a gestational carrier or a surrogate. But I also emphasize that if they wish to conceive, then they go in, preferably knowing the risk. We will do our utmost to take care of them that we possibly can, but we do not know where the outcomes can go. And in particular, in these situations, if we're talking about a mom who's deteriorating, and she's 24 weeks in gestation, she's in the ICU. In those cases, not only are we looking at a mom who's critically ill, but we're also not uncommonly looking at a preterm baby who may incur long-term morbidity as a consequence of that preterm delivery as well. But I do emphasize to those moms that we will be there for them, whatever decision that they would make.
Next question is, what is the max pulmonary pressure that would preclude pregnancy? That's
Good question.
Yes. Moving target.
Yeah.
Yeah. I think it probably depends on RV function, wouldn't it, more than anything else?
I think it kind of all of it together. Yeah, I think.
No.
Yeah.
I think, when we think about the right ventricular systolic pressure, there's multiple determinants of it. The left atrial pressure being one of the major drivers for the pulsatile pressure, but the amount of flow, as we talked about, of course, pulmonary vascular resistance, but right ventricular function is really, really important. So, you may have a patient with significantly reduced right ventricular systolic function, severe PH, and an RVSP that's not significantly elevated, but their PVR is through the roof. And so I think looking at just that one number, unfortunately, can potentially mislead us. And so we have to look at the patient in whole, look at their echo in whole, and if they have invasive data, look at that all in context. And then kind of getting in terms of trying to actually answer that question, not just punt. I will just say that, there's been some interesting data in the recent past couple of years looking at either patient with Eisenmangers or significant PH and showing that, some of them can actually do okay with pregnancy, not zero risk, but not as high as we previously thought. I think that some is due to earlier recognition, advances in treatment. But I think, it certainly is a formidable undertaking to carry a patient or guide them through pregnancy with significant pulmonary hypertension, but it can potentially be done. And in terms of a max, I think that's an interesting question in that we don't know patients with a moderate degree of pulmonary hypertension. Is there a risk? Is it a linear risk, in terms of moderate versus severe? Or is there some exponential risk once you get to a certain PVR or RV dysfunction or PA pressure? It's an interesting question, and I'm not aware of data that really outlines that.
No.
This kind of question kind of goes along with it as far as management of pregnancy in women with pulmonary hypertension. And then how often do you recommend pregnancy termination? And if they refuse that, do you follow the, how often do you follow the patient? I think you were kind of addressing that, you counsel on risks.
Yeah, the technical answer to that is if you look at the modified WHO criteria, any degree of pulmonary hypertension is considered a contraindication to pregnancy. And obviously there's probably a spectrum there. Usually quite about a 16% mortality risk is the most recent data that I've seen. And what we do during pregnancy is typically we will echo those moms at least every trimester, if not more frequently than that. We will, from 20 weeks onward, follow serial sonography. We will generally have our anesthesiology colleagues involved early, have a plan for the delivery aspect, both on a scheduled or an unscheduled basis in case the patient were to deteriorate in the interim. And in general, we have tried to achieve 34 weeks in those pregnancies. I haven't always been successful, but have tried. And a lot of that is based upon either onset of worsened clinical symptomatology or sort of achieving a gestational age where we really anticipate a very good outcome on behalf of the neonate and having all the resources available were a mom to deteriorate. That's what.
Yeah.
And just add a quick congenital spin to that. The other question is, even in the absence of pulmonary hypertension, but right ventricular hypertension, if they have an obstructed conduit or a pulmonary homograft, whatever it may be, we don't know if the risk is comparable to an RVSP of 80 if the PA pressure is an 80. And so there's a lot of unknown questions here, I think, in terms of what is really the driver of those high risk situations.
Next question is, do you routinely hold any medications such as antihypertensives or antiarrhythmics during delivery in case hypotension or blood loss occurs, or just treat if it does occur?
I would say during the labor and the delivery process, we don't generally hold medications. And usually my anesthesiologist, particularly if they're putting in neuraxial and they're worried that a patient will become hypotensive, will have a phenylephrine infusion running so that way they can titrate it to maternal blood pressure. And in particularly in a patient with, say, severe AS, they will usually have an art line in simultaneously. But I don't think we necessarily hold any medications in particular. I mean, off the top of my head, I'm thinking maybe anticoagulation, but otherwise, as far as antiarrhythmics or, inotropic, chronotropic meds.
Yeah. One thing I would just say is, getting back to an earlier question about safety of certain medications in pregnancy, but not in lactation. Certain antiarrhythmics do fall into that category. And so if the mother knows that they'd like to breastfeed immediately postpartum, then sometimes we'll hold, for that medication to wash out. So that'd be the only other thing I might think about there.
And then this may be kind of one of our last questions here, just given the time. But it says, are there situations when obtaining genetic testing during pregnancy for new diagnosis conditions, such as connective tissue disorders, would guide or change your management?
Thinking like an undiagnosed Loeys-Dietz or Marfan.
Yeah.
Yeah,
like a new diagnosis of Marfan, Ehlers-Danlos. Certainly, if it would change your monitoring, how you'd monitor the patient, how closely you would monitor the patient, if like from an aorta perspective, that could be important. And I think even if we're seeing someone for preconception counseling, or if they're already pregnant, we do like to involve genetics as soon, certainly whenever, as soon as we can for the women. So I think that if that resource is available, even if they're already pregnant, I mean, I guess I would not hesitate to really pursue that, because it potentially could add to your help you in terms of monitoring and kind of how, your risk stratification for that patient potentially.
And delivery decision making as well.
Yeah. Yep.
And then for the congenital heart disease population, certain diseases common like tetralogy of Fallot, while it may only carry a 4% fetal transmission rate, but if the mom has genetic abnormality associated with tetralogy of Fallot, autosomal dominant, now it's a 50%. So from a fetal screening standpoint, it has significant implications.
Great point. Yeah. Very good. Well, I think that, we have 1 minute left. I think we're going to take, just to wrap up and again, say thank you to everyone for joining us this evening. Thank you for the wonderful questions. We hope you had some good takeaways from our discussion here tonight. And again, we really thank you for joining us and hope you have a good rest of your evening. So thank you.